Preface. Nash 2015 poignantly states, "We know that 80% of what determines our health takes place outside the health delivery system." This insight underscores the profound impact of social determinants of health, SDOH, on individual and community well-being. Among these determinants, food insecurity stands out as a critical issue, influencing physical health and mental and emotional well-being. The Healthy People 2030 NWS-01 objective to reduce household food insecurity and hunger reflects a recognition that improving access to nutritious food is essential for fostering healthier lives. Addressing food insecurity through targeted policies and community programs is not merely about immediate relief, but nurturing the fundamental conditions that enable people to thrive outside clinical settings. By focusing on the broader context in which people live, work, and eat, we can create a more holistic approach to health that genuinely supports the well-being of our society. Part 1. Disparity. Disparity introduction. Food insecurity connects to adverse health outcomes impacting children and adults. When populations face food insecurity, they are at a higher risk for adverse health outcomes and chronic conditions. Research demonstrates that food insecurity is more prevalent in households with children, female-headed households, Black and Latino communities, Native American populations, and families headed by individuals with disabilities. The United States Department of Agriculture, USDA, Economic Research Services, ERS, predicts agricultural, food supply, and environmental trends. Its purview also includes rural America. The ERS researches and provides evidence to inform public and private policy and decision-making. It is a federal statistical agency governed by the Office of Management and Budget Statistical Policy Directives. According to the ERS, in 2022, 44.2 million people lived in food insecure households. 11.7 million adults lived in households with very low food insecurity. The differences between food insecurity and very low food insecurity will be discussed later in this presentation. 7.3 million children lived in food insecure households in which children, along with adults, were food insecure. In this chart of food insecurity, the ERS provides demographic and cartographic measures for food insecurity when comparing the race and ethnicity of households, Black, non-Hispanic, and Hispanic, experience food insecurity at over double the rate compared to white, non-Hispanic households, at over double the rate. This next chart provides details on food insecurity prevalence by household characteristics. Let me now summarize the evidence of food insecurity. The analysis of the number of individuals and their characteristics living with food insecurity, combined with evidence linking food insecurity to adverse health outcomes and chronic conditions, indicates that both Black, non-Hispanic, and Hispanic households are vulnerable to higher health burdens based on their race and ethnicity. Part 2, Historical Review of Food Insecurity and Populations Affected. Background and historical review of food insecurity. Reports and research from the 1980s laid the groundwork for collecting food insecurity data starting in 1995. For example, the Surgeon General's report on nutrition and health, published in 1989, provided evidence of the connection between nutrition and overall health. The report presented extensive research showing that poor dietary habits were a significant risk factor for many chronic conditions. Furthermore, the Surgeon General report recognized the disparities in health outcomes among different population groups, including minority populations. The report emphasized that minority groups often experience higher rates of chronic diseases such as diabetes, hypertension, and heart disease, which are closely linked to diet and nutrition. The report acknowledged that social determinants of health, such as socioeconomic status, education, and racial discrimination, significantly influenced health outcomes. It also emphasized that systematic barriers, such as limited access to healthy foods, safe neighborhoods, and quality health care, disproportionately affected minority and low-income populations. Overview of food insecurity. Ham and Bellows in 2003 provide an explanation of food security and delineate 3 crucial factors to consider for food insecurity. Firstly, does the region produce enough food to meet consumption needs? Secondly, is the food supply stable and not susceptible to interruptions that would fall below consumption requirements? And finally, is there adequate access to food, meaning there is enough supply, but some people lack the physical or economic means to obtain it? Now, according to the USDA-ERS, in 2024, the United States produces enough food to meet the consumption needs of its population. The U.S. is one of the largest agricultural producers in the world, with a significant surplus in many food categories. The country's advanced agricultural technology, favorable climate, and extensive arable land contribute to its high productivity. Of the 3 factors of food insecurity, physical and economic means overwhelmingly contribute to food insecurity in the United States. Data collection of food insecurity. The first current population survey, CPS, for food insecurity was conducted in 1995, marking the beginning of systematic data collection of this critical issue. Since then, the Food Security Supplement has been administered annually, providing valuable insights into the prevalence and severity of food insecurity in the United States. These surveys contribute to inform policies and program development aimed at combating food insecurity nationwide. Now let's move on to characteristics of households with very low food security. According to the ERS in 2024, food insecurity is measured on a scale ranging from food security to very low food security. This is done using tools like the Current Population Survey, the CPS Food Security Supplement. Households with low food security report reduced quality, variety, or desirability of diet, but little or no indication of reduced food intake. On the other hand, households with very low food security report multiple indications of disrupted eating patterns and reduced food intake due to insufficient resources for food. These scales help identify and address the severity and prevalence of food insecurity across different populations. Here's a chart for the percentage of U.S. households reporting indicators of adult food insecurity by security status as of 2022. When the previously presented data of the characteristics of individuals living with food insecurity is combined with the evidence linking food insecurity to negative health outcomes and chronic conditions, it becomes evident that there are systemic racial disparities for Black and non-Hispanic and Hispanic households are more vulnerable to higher burdens based on their race and ethnicity. Part 3. Impact of racism and trust. Let's review an example of racism and trust for a population impacted by food insecurity, specifically for the Black non-Hispanic population. The impact of racism and lack of trust on an individual's health is significant. When people don't trust medical institutions, they're less likely to use preventative services and may delay seeking treatment, leading to worse health outcomes. For instance, the Tuskegee syphilis study, where African American men were deceived and denied treatment, has had a lasting effect on trust in medical institutions. Additionally, community-level mistrust, often fueled by experiences of discrimination, weakens social cohesion and access to supportive networks, further exacerbating health disparities. Part 4. Policy and laws related to food insecurity. Gaps in policy. In Beyond Food Deserts, according to the Brookings Institute 2024, the United States currently has several programs to address food insecurity. However, the Brookings Institute goes on to explain that a major issue is the inadequate funding and coverage of nutrition assistance programs such as the Supplemental Nutrition Assistance Program, SNAP, and the Special Supplemental Nutrition Program for Women, Infant, and Children, WIC. These programs often face budget constraints that limit their ability to serve all eligible individuals. Furthermore, the benefits provided by these programs are frequently insufficient to cover the full cost of a healthy diet, leaving many participants vulnerable to food insecurity. In addition to funding challenges, there are concerns about food access related to these programs. The Economic Research Service, ERS, provides an atlas to assess areas where both low income and low access to food. This map helps to identify areas with limited access to food. Here's a comparison of the ERS Food Atlas and Google Maps. When examining Raleigh, North Carolina, where I live, using the ERS Food Access Research Atlas, I compared the areas of low income and low access for Raleigh, North Carolina, with Google Maps to display grocery stores in the same geographic region as the Food Access Research Atlas. It is evident that individuals with low incomes face a significant hurdle in the form of limited grocery store access, which in turn adversely affects the quality of their diets. According to Zhang and Ghosh 2016, this is an example of how systematic racism, impacts access, including the persistent effects of redlining, where chain supermarkets are disinclined to locate stores in impoverished neighborhoods. Part 5. Key players locally and nationally supporting policies. National players supporting policies and programs related to food insecurity. 1. The USDA Food and Nutrition Service, FNS, oversees the nutritional assistance programs. The USDA manages several programs, but Assignment 4 only mentions a subset. The Supplemental Nutrition Assistance Program, SNAP, benefits low-income families to supplement their grocery budget. 2. The USDA Economic Research Service provides evidence-based research to inform policies impacting program funding and performance. 3. Feeding America, nationwide network of food banks, food pantries, and meal programs. 4 is the National Grocers Association, NGA, is a consortium of grocery stores that includes supermarkets and controlled food retail companies. The NGA partners with federal nutrition programs like SNAP, ensuring that beneficiaries can use food assistance benefits at retail outlets nationwide. One example of the impact of NGA is its support of digital payments for SNAP. When paying digitally at a grocery store or pharmacy, they accept electronic benefits transactions, EBT. The Office of the National Coordinator for Health Information Technology, ONC, supports adopting health information technology and promotes nationwide standards-based health information exchange to improve healthcare. ONC provides standards for capturing clinical data, including social determinants of health. 6 is Health Level 7 International, or HL7. Their Gravity project is a collaborative effort involving a wide range of experts who are committed to addressing the information exchange requirements that promote health equity and improve population health. This project is part of a technology accelerator initiative aimed at helping health and social care organizations to share data using standard terminology and technology easily. Next, let's talk about state players supporting policies and programs related to food insecurity. The North Carolina Department of Health and Human Services, NCDHHS, oversees several programs addressing food insecurity in North Carolina, including the state's administration of SNAP, WIC, and the Child Nutrition Programs. They work to ensure that all eligible North Carolinians have access to food assistance programs. The NCDHHS Child and Healthcare Food Program is a federally funded program that is administered and funded by the United States Department of Agriculture, FNS. The purpose of the program is to ensure that all eligible children and adults who attend qualifying non-residential care facilities receive nutritious meals. The NC Care 360 provides referral coordination, connecting individuals and families to resources that impact physical, behavioral, and social wellness. This service helps link those in need with appropriate resources, including food assistance programs, to ensure a more holistic approach to tackling food insecurity. Part 6, Areas of Opportunity regarding this disparity to actively support. Social determinants of health data interoperability. As a student of the Wake Forest Medical Informatics program and with a professional background in clinical data interoperability, I would like to support the area of food insecurity by connecting clinical data with a central repository to identify information that enables faster decision-making for policy support to facilitate health equity. Within the HL7 Gravity Project, there are work streams to support standards development and provide tools for adoption. For example, the Gravity Project has developed tools specifically to improve data collection for SDOH, including food insecurity. The Gravity Project is developing data collection values to capture clinical data for social determinants of health. Here are ICD-10 codes to capture the reason for a clinical service. For example, in Z59, there are codes specific to problems related to housing and economic circumstances that include a lack of adequate food. See Z59.4. Part 7. Propose a law or recommendation to help mitigate this disparity. Integrating data for addressing food deserts and improving nutrition access. Let's start with an overview. Integrating data from the Gravity Project, electronic benefits transfer EBT systems, and Centers for Medicare and Medicaid Services, CMS, can enhance our understanding of food deserts and improve nutrition access in underserved communities. Let's review the components. So first will be the clinical data collection. The Gravity Project collects comprehensive data on social determinants of health, including food insecurity. The clinical records are aggregated into a population health data and can be used to identify at-risk populations and understand the broader context of their health and living conditions. See, the EBT systems capture detailed information about food purchases made through the Supplemental Nutrition Assistance Program, SNAP. Analyzing EBT data provides insights into consumption patterns, the types of food purchased, and the locations of these transactions. This information is critical for understanding the food purchasing behavior of low-income households. The next component is the Centers for Medicare and Medicaid Services, CMS. Clinical data aggregation for CMS data includes health information related to Medicaid and Medicare beneficiaries, many of whom may also be experiencing food insecurity. Linking CMS data with EBT data allows for a comprehensive analysis of health outcomes related to nutrition and food access. Now that we understand the components, let's talk more about the solution. Let's start with the data by mapping EBT transaction locations and analyzing CMS health data alongside the Gravity Project SDOH data. We can identify food deserts with limited access to affordable and nutritious food. This integrated data approach enables precise geographic pinpointing of where interventions are needed the most. Next, as part of the solution, let's talk about Feeding America, integrated data to optimize food bank distribution networks, ensuring food assistance reaches the most affected areas. Targeted food programs can be designed to meet the specific nutritional needs of these communities, informed by the integrated data insights. Next, the National Growers Association, the NGA, helps address food access in identified food deserts. Policies can encourage grocery stores to open and sustain operations in underserved areas by providing subsidies and tax benefits. This solution not only improves food access, but also stimulates local economies. The government and private sector subsidies, it is crucial to ensure that NGA and other food retailers can operate in low-income areas. These subsidies can offset the higher costs and lower profit margins associated with these locations, making it a viable option for stores to provide fresh, nutritious food. As part of the solution and connection to Healthy People 2030, by connecting these data sources, we can identify areas with significant food insecurity and strategically deploy resources from Feeding America and the National Grocers Association to ensure better food access. Subsidies and support policies will further enable grocery stores to serve these communities effectively. This holistic approach addresses both immediate food needs and long-term health outcomes, contributing to the goals of initiatives like Healthy People 2030. Part 8, Healthy People 2030. For Healthy People 2030, NWS-01. Here's a summary. Healthy People 2030 Objective NWS-01 aims to reduce household food insecurity and hunger in the United States. This objective recognizes that food insecurity connects to various negative health outcomes such as obesity, chronic diseases, and developmental issues in children. By increasing participation in nutrition assistance programs like SNAP and addressing broader socioeconomic factors like unemployment, the objective seeks to lower the proportion of households experiencing food insecurity from a baseline of 11.1% in 2018 and is getting worse. The most recent data in 2022 is 12.8%, and the original target was 6%. So it's going up, not down. The focus is on consistency with national policies and programs to ensure sustainable improvements in food security across diverse communities.